but it is very difficult to manage the deep infiltrating endometriosis. As you know, the pathology of this deep infiltrating endometriosis is entirely different from the routine endometriosis for few reasons. One is hormonal function is totally altered, immunological factors are totally altered, peritoneal macrophages have come in a big way, natural killer cells have come in a big way. The disease is like a fire. If you don't diagnose, if you don't treat immediately, you are ending with it. And another very important thing about this disease is its aggressive behavior. It is like a malignancy. I think this is a very typical area where today Dr. Sandesh will be addressing us. I think his extensive knowledge, his extensive surgical skill really fits into skill transfer program. Today, whatever skill our Sandesh has gained over the last 1 decade, probably he is going to transfer to our Kcog members. And now I request our President, Dr. Kasturi, to give her the address.
Good evening, sir. Thank you for your excellent message. First of all, I thank whole Kcog family and our Chief Patron, Dr. M.J. Ramat sir, Patron, Dr. Nagaraj sir, and Secretary, Dynamic Secretary, Dr. Bharti, Treasurer, Dr. Durga Das, and whole EC, and all the Kcog Kcog team, headed by M.J. Ramat sir, and Dean, Dr. Hema Devakar madam, and Chairman, Dr. Muralidhar Pai sir, and Dr. Vidya Bhatt, Secretary, and Vice Chairman, Dr. Basura Sajjan, for taking up this Kcog Kcog in a big way. You know, this is the first time our state is having Kcog Kcog like in parallel with ICOG. In none of the other states in India have this. So this is a brainchild of our Chief Patron. So thank you, sir, for bringing up this. And especially the skill transfer program is excellent. As you told, most of the members are waiting for this program, skill transfer. So thank you for bringing up this. And thank you once again for bringing such an excellent surgeon, Dr. Sandesh Kade. I just don't call him, he's not just national, an international surgeon. Half the month he is in India and alternate week he is in either in Abu Dhabi or Dubai. So it's such a pleasure and it's our proud moment to have such an international surgeon amongst us. And thanks to COVID and Zoom, that week, even though he is in Abu Dhabi operating, from his operation theater, he is able to address us on this important topic. As sir told, it's very, very important topic. The youngsters are suffering from this endometriosis. It's a long-term suffering. It is sometimes it is more agonizing than malignancy. You know, long-term, the amount of pain and the other symptoms which they suffer is too much. So, sir, thank you for taking up this topic. And everybody is waiting for to listen to your pearls of wisdom. So, thank you once again. Thank you, whole Kcog Kcog team. And the stage is open for you, sir.
Okay. Thank you, Madam Dr. Kasturi, President of Kcog, for giving such a warm welcome. Now I request the convener of the program, Dr. Vidya Bhatt, the Secretary of Kcog, to kindly introduce this eminent faculty to the audience.
Thank you, Dr. Bharti. Thank you, Dr. Bharti, and thank you, Hiramat sir, for accepting my thoughts, because whenever we have a discussion on every month end, whom to call, we say this has been done, and we are almost reaching the first year we are completing next month. We started in July last year, and every skill program has been with excellent surgeons. And today, to talk about DIE, or deep infiltrating endometriosis, we have Dr. Sandesh Kade, a very dear friend of mine, and a very handsome surgeon also. And above all, he is a dedicated person in skill transfer. I think he is a person who had to be called long back, because he completely concentrates on the skill. I have seen him how dedicatedly he operates, and every step he's so meticulous. And to introduce him, he has been the first uterine transplant surgery which was done in India. He has been a part of that. And then you know that he is a international laparoscopic surgeon, and we are really very proud of you, Sandesh, for transferring your skills not only in India to other parts of the world also. And he always gets involved in any of the skill transfer courses. You tell him, Sandesh, you have to make it, he is there. In spite of his busy schedule of 15 days in UAE and 15 days in India, he makes time for these skill transfers courses because he has been involved in PLH training, and then he has been involved in radical hysterectomy training in Galaxy hospitals. And his videos are very well appreciated, and he has got the award for best videos in IAG, ISGE, and AAGL conferences. So very nice to have you here, Sandesh, and thank you so much for accepting my invitation. Thanks a lot, and over to you for your knowledge on DIE, because I have seen you talk about even the transvaginal, transvaginal scan, how you diagnose DIE, the movement of the transvaginal probe which you show in your videos. I mean, you really concentrate on all those things. So over to you, and thank you so much for being here with us.
Yeah, thank you very much for this wonderful opportunity. And I am really happy to know that this surgical skill transfer is happening. And I have been invited to speak on a very favorite topic of mine, that is deep infiltrating endometriosis. To begin with, and as you said, there are a lot of students here. So let me tell you that my training is still ongoing. I have been initially trained with Dr. Hafiz. Yeah. And then I got the radical training with Dr. Puntambekar sir. And then this topic, like it is graded for all of us. You start doing TLH, then you start doing myomectomies, then you start doing radical hysterectomies. And finally, it is the peak comes when everybody of us would like to perform surgeries on deep infiltrating endometriosis. And for that, I have always traveled across the world. And I'm very happy that I got a lot of knowledge from Dr. Adel Sherwin in Iran, and he used to work in US. Now you have Arnold Vatiez, and most importantly, for past 3 years, every 3 months, I am visiting France, one of the best centers that is called as Tivoli Ducox. All of you, whoever is interested in these surgeries, I would recommend to really visit that place. They perform the highest number of bowel surgeries in endometriosis, and also they perform only the grade 3 and grade 4 endometriosis. So thank you to all my teachers who have imparted all this knowledge to me, which I think I will be able to share and transfer in this particular program. So we'll begin with what is deep infiltrating endometriosis. See, endometriosis is a chronic, almost incurable, estrogen dependent disease, which is an inflammatory process. Now, the endometrium like tissue, it's not the true endometrium, but endometrium like tissue is outside the uterus into the pelvis or extra pelvic sides, and it causes all these problems. So when this tissue, it invades into the peritoneum or into the retroperitoneum.
Sir, your slides are not moving.
Yeah. Then we call it as the deep infiltrating endometriosis. So basically, there are 3 types of endometriosis. I'll just reduce this.
Now we can see.
Yeah. So basically, there are 3 types of endometriosis. The superficial peritoneal endometriosis, which very commonly we pick up now because we have understood how it looks. Maybe those red spots, white spots, or powder burn appearances, or those windows, which are the peritoneal windows which form. To tell you that even if you have superficial peritoneal endometriosis, it can be very, very painful. So we have to address even this type of endometriosis. Second is the ovarian. Now, very often the clinician picks up the endometriosis only when he sees an endometrioma. So for most of us, the endometriosis diagnosis happens only if the patient has a endometrioma, a chronic cyst in the ovary, which does not fade away with medications, and the patient has severe pain. And so that is when we pick up. But to tell you, the ovarian endometrioma is just a tip of an iceberg. It is actually the very late representation of the disease, and it is not the beginning of the disease. And the most third important part is the deep infiltrating endometriosis. There are many theories how endometriosis is formed. So the most common and publicized one is the retrograde menstruation, where the uterine blood cells, they go into the peritoneal cavity. Now our body has a potential to kill these cells, but some cells survive, they stick to the peritoneum, they grow in that adverse conditions, and they infiltrate, they produce adhesions, and under the influence of estrogen they proliferate and they produce neoangiogenesis. And this is the reason why you have this very severe form and aggressive form of disease, which almost mimics like malignancy. So this is the best paper presented by Nisol, where they have told that there are these 3 types of endometriosis. And today we restrict our topic to the last one, that is the deep infiltrating endometriosis. So the most important crux of this disease is like smooth muscle metaplasia, like what you have in malignancy. So in this smooth muscle metaplasia, what happens is the tissue invades into the retroperitoneum and it produces fibrosis. That is the reason why you have to cut and excise this tissue, and a lot of times it does not respond to the medical line of treatment. It produces a lot of retraction of the tissues, distortion of the anatomy, leading to hydroureters, hydronephrosis, infertility, and severe pain and nerve involvements. So it invades into the underlying tissues, even into the lymph nodes, metastasis. And because of this nature and its neoangiogenesis, it bleeds. So the resection is a challenge, and complications are very common in the surgeries of endometriosis. Larger the deep infiltrating endometriosis, more difficult it is, more challenging it is, and we should explain the complications and potential limitations which happen with these type of surgeries. The patient typically presents to us with dysmenorrhea, deep dyspareunia, chronic non-cyclical pelvic pain. Sometimes initially in the endometriosis, you have cyclical pain, but we have a habit of telling these young girls that, okay, pain is normal, but actually we should be aware that it could be endometriosis. And then when it spreads to the other organs, maybe the gastrointestinal symptoms will come up. These patients, if they go to severe form, they will have chronic constipation, alternating diarrhea, and we have patients of subocclusive and occlusive disease where the patient lands up into bowel obstruction because of endometriosis. And so we have to find them early. In bowel endometriosis, okay, you can get away with doing some disc excision or shaving of the bowel or resection. But if it is urinary tract endometriosis, it's called as a silent killer. So we have to be very, very careful and very vigilant in picking up these patients, because it's a very debilitating disease and it affects their lifestyle, their regular functioning, and it is really a physical as well as a mental torture to these patients because it just keeps on recurring. So most important also is the presentation, that is in the form of infertility. We really do not know, because patients can have pregnancies also with endometriosis. So whether it is the cause and effect factor is not established, but very often the endometriosis can lead to poor egg quality and poor implantation and anatomical challenges. So the biggest apathy is the late diagnosis. These young girls, when they have these problems at menarche, they usually start telling this to their elder sisters or their mother. And then they have the habit of trying to pacify her, saying it's okay, it's normal. Your sister had it, I had it. And then they keep on just counseling them. until it takes almost 2 to 3 years for them to reach the general practitioner. There they start receiving the painkillers, the antispasmodics, the anti-inflammatories, till finally they find that it is not getting treated, they reach the gynecologist. So it is almost 5 years before the problem starts in the patients. And the gynecologist routinely in our practice, we pick it up only when you do an ultrasound and you see an endometrioma. Till then, the disease is not picked up. And this is not the story of India alone. This is world over. This is a very beautiful paper on adolescent endometriosis, where there is a diagnostic delay, and the average delay world over is 7 years. And such an aggressive disease which can really affect the bowel and ureter and nerves, we imagine it is picked up after 7 years. Very often I find this very difficult when I do surgeries for endometriosis. You know, my colleagues, they always feel, oh, he's a very radical surgeon, she's such a small girl, and even then he is being so ruthless and operating. Now, what I want to tell them in clinical aspect is that because this girl has developed such a severe endometriosis in so early age, imagine what is going to happen to her in so many years till menopause. And believe me, it does not go with menopause. It still continues. I'll explain you what happens in post-hysterectomy patients also are there with endometriosis and deep infiltrating endometriosis. So earlier the disease, it is more aggressive and she has many years to suffer. So we have to be more aggressive in the younger age group actually, clinically. But what happens is we are actually treating this on an emotional level, and nobody likes to go for those aggressive surgeries. So this is a practical difficulty we face as endometriosis surgeons. So now the topic given to me is the diagnosis and the surgical treatment of deep infiltrating endometriosis. This is one of the best papers that is available by Bezot and his colleagues, where they have shown that you can diagnose endometriosis on clinical grounds, on transvaginal sonography, on CT scan and MRI. But when you diagnose endometriosis clinically, by the time you feel the pouch of Douglas and the uterosacral nodularity and the rectovaginal endometriosis, it is very late. So it takes years before these nodules develop, and the disease has really gone from superficial peritoneum to retroperitoneum to parametrium, and then it is presenting to you in the uterosacrals and vagina. So if you see a very small tag of tissue in the vagina, believe me, it is just the reverse iceberg. It is, you are seeing the tip here. The whole disease is in the paracolpus and parametria, which you are not seeing there. So if you feel a 2 to 3 centimeter nodule, the disease is very, very advanced. So what we have to do is pick it up early. And then it has been shown that ultrasound and MRI are very good. They have very good sensitivity and specificity for picking this up. Now, what you perform, ultrasound or MRI, is up to you. Because why I'm saying this is because there are many very good centers in Europe who perform endometriosis surgeries only with ultrasound. And there are some centers who exclusively do MRI. Now it is, both of them are happy because the sensitivity and specificity is about 96-98%. So it is the skill development. So you have to have a multidisciplinary team where radiologist is one part of it. And you have to teach them. There has to be a very good dialogue between the radiologist and the operating surgeon. Earlier, you will find the radiologist under-reporting and the surgeon finding it very, very difficult in the surgery. And when you don't have a dedicated ultrasonologist or a radiologist who reports your MRI, and if you do not discuss, then you are always going to be repeatedly getting surprises in the operation theater. Now, when you develop a team, there will be no surprises. There are very good papers to show that the pre-operative diagnosis and the intraoperative diagnosis has almost come to the same level. So rarely you will find like a very surprise, and you will come to decision making where you have not counseled the patient, or the patient has not given signature, and now you feel that, okay, what should I do, whether I should go ahead. So it is very important. And most of the things which you are going to perform in the surgery, these are very critical and crucial, because you cannot wake up, the patient cannot wake up to find a colostomy on her abdomen, and the patient cannot wake up to find that her kidney has been removed. So you have to tell her in advance. Even all these procedures, it is quite possible to explain each and everything. It is quite possible to actually give a clear picture to the patient what realistically she should expect from the surgeon, and what is going to happen, whether we are going to preserve her tubes, whether we are going to actually do disc bowel shaving, or she can land up with a disc excision or bowel resection. So everything can be explained pre-operatively. It is only a matter of having few good dedicated radiologist friends, or if you are doing an ultrasound or reading your own MRIs, then sitting with them and learning it for yourself. If you are in the remote places, there is no option. But if you are doing a sonography, MRIs you can send across the world and get a good diagnosis. Not a problem at all. So these are few, I am going to share few good pictures of picking up endometriosis. And so see, if you see now, here you will see there is a bowel line, and suddenly the bowel line, it becomes very thick. And this is something like, it's called as a comet sign, where you have retrocervical, you go behind the cervix, start tracing the bowel line, and this bowel line suddenly becomes thickened, and that is exactly the part where the pain coincides. So this is something like a comet sign. When if you have a rectovaginal nodule, and now in this example, this black thickened line is on the bowel and not on the vagina. If you appreciate the vaginal probe, the semicircular line, and the white line, which is the vagina, the yellow asterisk which is shown is the vaginal wall, and the green part is the bowel. And so the black comet sign is on the bowel. So this is typically bowel endometriosis, which is invading into the muscular layer, but there is not a drop of adhesion or sticking to the vagina. So if you are depending on your vaginal examinations, you will never pick up this disease which has already invaded the bowel and it has not reached the vagina. So rectovaginal endometriosis could be only on the rectum, it could only be on the vagina, it could be both on the rectum and vagina. Depending on this, you will have to tell the patient that in your surgery, madam, I am going to excise both the rectum part as well as the vaginal part. Now, what is the clinical importance? You are going to have two suture lines. There is a chance of fistula formation. So all these things have to be picked up pre-operatively to explain, and the patient has to consent and accept all these things. Usually acceptance or is not a big problem. That's what we find. The problem is we just see the ovarian endometrioma and we just drain it and come out, and then the uterus is just released. But this is really not the, what is actually required for the patient. We need excision surgeries in deep infiltrating endometriosis. So now this is an example of the nodule extending both to the vagina and to the rectum. So here you will see the thick line becomes suddenly thick, comet sign. The black tissue extends both, it touches the probe as well as it is towards the bowel mucosa. So this is a case of rectovaginal nodule extending both to the bowel as well as to the vagina. So this is the case which you should explain, that if at all there are two suture lines, there is a chance of its adhesion and fistula formation. The other one, okay, it is, I would say, even if fistula forms and you pick it up, it is okay. But what if the patient has no vaginal sutures and it is just a bowel leak? And if you pick it up very late, post-operatively, if you do not pick these cases early, these patients would be found only in sepsis, and it's a very, very late condition. And bowel injuries and bowel leaks are very notorious in their post-operative behavior. So you have almost a very high number of mortality. Now, when this nodule starts becoming thicker, it starts producing spikes and it starts pulling the bowel mucosa. And that is when it starts giving what is called as an Indian headdress sign, or where you have a hand in glove sign where the bowel gets pulled. So this is the spikes which come, and then the bowel is pulled in multiple areas. So if you have a nodule which is 3 centimeters and more than 7 millimeters deep, then it is almost gone into the bowel. In this case, you cannot have just adhesiolysis, you have to excise the bowel. So this is the typical moose antler sign or the Indian headdress sign, where you have that feather crowns which these red Indians wear, and you have this typical picture coming up, and you know that this is a severe form of deep infiltrating endometriosis. And this is finally the subocclusive disease, where you see something like a mushroom nodule. This is like from the cervix, you have some tissue growing into the rectum, and this rectum just pulls it up and it forms like a mushroom hood. And here we have put fluid into the rectum, and then you can see it got distended. Otherwise, you can appreciate how narrow the lumen has become from this nodule to the posterior wall of the bowel. So here it is almost after distension, it is showing some space. Otherwise, this is subocclusive disease, and these patients can go into bowel obstructions. So this is a case of where you have 2 nodules just coming out with 1 nodule and the other left there. The whole purpose is lost, and the patient still continues to have her problems. So it is very important to pick this disease. This can also be picked up into the anterior compartment, where you have the bladder endometriosis. So this is typically found in cases where you have these incisions on the uterus, the cesarean section scars, the hysterotomy, the DNCs, adenomyosis, which extends into the anterior compartment and can go into the bladder. Now, I don't know exactly why, but the bladder nodules immediately perforate and go into the bladder, and they produce hematuria. The patient can present with hematuria, but the rectal nodules very, very rarely actually go through and produce perrectal bleeding. So by and large, now we are not performing colonoscopy. Very often people with these complaints end up performing colonoscopy and they find nothing. So by nature, the disease does not perforate into the rectum and produce bleeding, whereas it is very easily perforates into the bladder and then it produces hematuria. So we have to be careful. This has to be picked up by the gynecologist. If you send it for a colonoscopy and expect the bowel surgeon to tell you, he will not see anything there. So we have to learn to pick this disease. And here is an example of the bladder nodule. So you see the anterior compartment at the cervical part where it has obstructed the ureter and the ureter has distended. Now we have to pick this type of disease. The patient rarely complains because the ureteric endometriosis is painless in most of the patients, and it is picked up by the time it has already caused the hydroureter and hydronephrosis. So we call it as a silent killer. So we have to pick it up. Now with MRI, what I find is you are even able to pick up those patients which are having difficulty in sitting, difficulty in walking. Now yesterday I was sent a patient of ovarian endometrioma, but when I looked at her, she was sitting with actually her one thigh and one buttock raised. And I asked, like, why don't you sit comfortably? She says, I sit like this. So when we examined, the disease has gone to the sacral nodule, sacral nerve, and she has muscle wasting. And if you see her MRI, the buttocks, one buttock shows complete wasting, and she has lost that muscle. And that's the reason she cannot sit properly. She cannot climb the stairs properly, difficulty in walking. So do not ignore these endometriosis patients with backache, with leg sciatica like pain, or dysuria. This, by the time the patient says, I have dysuria and urinary complaints, believe that the nerves have already fired. So we have to be very, very early and pick these cases of severe endometriosis which lead to hydroureter, hydronephrosis, or neurological involvement. And we should be tying up with our radiologist friends and picking these cases early. And also ask them that there is a classification, NZN classification, AHL classification for radiologists, and try to correlate between your surgical classification and their preoperative, and slowly you will find, and it is fun. You learn and you actually find it very interesting that your classifications from both sides are going, and then you will also find indirectly that you don't have hassles from your patients. They are not surprised with all those radical surgeries being performed, or even like explaining and counseling becomes very significant and easy for them to correlate. So also we use endometriosis to do follow-up scans. Now in this case, you can see a nodule which was there in 2012 and 2015. It increases in size, and now the early disease which was superficial has now gone into the bowel, and now it's become like a mushroom, and this patient would have otherwise had just bowel shaving or disc excision now ends up with resection. There are a lot of problems which happens. I'll explain you when we come to bowel endometriosis, what is called as low anterior resection syndrome and what is the difference in all these cases. So friends, deep infiltrating endometriosis, do not go by ovarian endometrioma. It is just the tip of an iceberg. It could be the disease starts going to the parametrium. In the parametrium, when this active disease is there on the peritoneum, the ovary will come and stick to this, and then it starts ovulating and it starts bleeding. This endometrium starts responding. So most of the time, the endometrioma is an extra ovarian beginning, and that is what is being pushed is actually the posterior part of the ovary, then the cortex and medulla, and then the cortex which faces you. So do not start cutting the ovary from this side. You are cutting the cortex, the medulla, the cortex, and then you reach the cyst. There are different techniques, but today's topic is on DIE. We are not going to touch upon the ovarian endometriomas. So here you can see this is the advanced parametrial involvement, and then it can start pulling it. It medializes the ureter and it pulls both the ureters to the center. And if you are in a habit of going from the central dissection, then there could be chances of ureteric injuries. It can also go to the bowel as a small spot and then go in, pulling the bowel towards it and invading into the myometria, into the bowel wall. And the ureteric endometriosis, as the nodule increases in size, the ureter starts getting involved. And I'll show you one very beautiful paper at what level the ureter is never spared. So you can have a hydroureter or a hydronephrosis. So this is how a deep infiltrating endometriosis is behaving behind the retroperitoneum, which we do not see if you perform just laparoscopy. If you see a small spot, then we usually have a habit of calling and telling the patient, you have mild endometriosis. Actually, the spot is nothing. It is actually the disease that is hiding behind the curtains. So now, the most common type of deep infiltrating endometriosis, that is the colorectal endometriosis. And we have found that the commonest site of the involvement is the rectosigmoid junction. So you have the disease starting at torus cervicum, the uterosacrals, and then it pulls the bowel. So rectosigmoid, then you have the sigmoid involved, then you have the small bowel involved, and very often you have the appendix. That is almost 6 to 12%. The appendix is also involved, and these patients need the surgery to relieve them of their bowel symptoms. So how do we judge and how do we treat these patients? So there's a very good patient by Maurice Abreu, which gives a very good guideline that if this patient has 3 centimeters nodule with 7 millimeters of infiltration, and it has involved the 50% of the bowel circumference. So you need to see the length of the nodule, the depth of the nodule, and its circumference. So if it is 3 centimeters, 7 millimeters depth of invasion, and if it is more than 50% involvement of the circumference, then those patients, they need segmental resection. If it is lesser than this, then you can come away with disc excision. And if it is still less invasion, then you can even come away with the bowel shaving. Now, what is the difference in all these 3 treatments? in bowel shaving, you are going superficial and excising the disease, but you are not opening the bowel. And because of this, when you don't open, the whole length of the bowel is preserved. So the concept we have to understand in rectum is, see, the rectum is only organ which can distend to a great extent without allowing the pressure to go ahead. I'll repeat this. The rectum is the only organ which can distend without allowing the pressure to go ahead. So even if you have severe distension of the rectum, the pressure will not go to the sphincter. The sphincters are not damaged. Okay. Now, if you are late in diagnosing and you do bowel resection and you remove rectum, the patient cannot have distension. So as soon as the stools arrive towards the sigmoid and the anastomosis, the patient cannot have distension. She cannot wait, and she has to go to washroom immediately. And can you believe that these patients with low rectal resections, they have to go almost 15 to 20 times a day to washroom. So she is more in the washroom than in her classroom or the office. So she actually ends up with losing her job, losing her career, and it is very, very pathetic, and they are really suffering a lot. So the small decision between a disc excision, in disc excision, what we do is we preserve the length of the rectum. We just excise the anterior part of the rectum, the roof of the rectum. So what you have is just a small pouch posteriorly, but the whole length of the rectum is preserved, and these patients will not suffer what is called as LAR, that is low anterior resection syndrome. So this is the importance of picking up this disease early or being aggressive and treating them, rather than trying to shy away from performing these surgeries, or trying to criticize somebody who is doing this, saying that, oh, he is too aggressive and he does it too often. It is the disease, and very often you will find these patients having bowel symptoms and neurological symptoms and urinary tract symptoms. So we have to understand it is not just the disease of ovary, but it is of the whole pelvis. Okay. And in cases where it has really gone beyond, then there is no option, but you have to perform the bowel resections. So this is about the bowel endometriosis. Now coming and discussing something about the urinary tract endometriosis. This was the paper which I was discussing. If you have a nodule, it is three. Am I running out of time? You just let me know. I'll stop. How much?
Sir, you can continue. Please continue.
Yeah. So if you have a nodule of 2 to 3 centimeters by 3 centimeters, it is almost 60% of the times the ureter is involved in that nodule. And if it is more than 4 centimeters, 90% times. So by the time we pick up something like 3 centimeter, 4 centimeter, first of all, we are not training our eyes to see how an endometriosis looks, deep infiltrating. Okay. So if our eyes are not knowing, we don't know, the eyes will not see that. And then we will miss 3 and 4 centimeters. And if it is 4 centimeters, 90% of the time ureter is involved. So you have to perform a good ureterolysis. If at all it's a severe intrinsic type that the disease has gone inside, you might have to perform something like segmental resection and then anastomosis. So here in this case of ureteric endometriosis, you have to take a call whether you will do the resection or just the adhesiolysis, or you will do the anastomosis. What we follow in our practice is proximal to the uterine arteries. If the ureter is involved, that is the part which usually has a good blood supply, we perform segmental resection and end-to-end anastomosis, ureteric anastomosis. So we can perform that and get away with it, like before the uterine arteries. From uterine arteries into the ureteric tunnel and into the bladder, the blood supply is very poor. So in these cases, it is always better to perform ureteric implantation. Now, taking very often a radical step of performing ureteric implantation is not so easy, because then you have retrograde, urine goes up, infection goes up, and pyonephrosis and hydronephrosis, and you can even lose the kidneys. So it is very important to know exactly at what location, whether it is intrinsic or extrinsic. Very often it is a very, very rare to have an intrinsic type. 85% is extrinsic. Most of the times a good ureterolysis would suffice, but only if it is intrinsic, then you have to perform the resection anastomosis of the ureter. So here in this case, proximal to the uterosacrals and to the uterines, this is a case where it is performed the resection and anastomosis. So now coming to the surgical aspects for the youngsters is, what surgery are we trying to perform? We are actually trying to improve and enhance the quality of life of the patient. We are trying to restore the anatomy of the patient. We are trying to improve her fertility and preserve the neurological functions of these organs. Because if these nerves, the disease goes to these nerves which are just besides the uterosacral ligament, 1.5 centimeters below the ureter, there you have these parasympathetic nerves, and these nerves are responsible for contraction. So they will contract the rectum, evacuate the bowel, they will evacuate the bladder. If you injure them, if you do not do it on both sides, bilateral endometrioma is very risky. If you injure on both sides, this patient will have chronic constipation and self-catheterization. She cannot pass urine, she cannot pass stools. So we have to be very, very careful. We have to be very, very selective in performing. If the patient has bilateral severe disease, the side which is affected most should be treated, and the other side. So it is now not what is called as radical surgeries. It is economical and tailoring of the surgeries. According to the requirement of the patient, we have to be less radical. We cannot be, because these patients are young, it is not malignancy, these patients are not old, and they have a big career ahead. So we have to be radical and economical in our surgeries. That is the line I want to share with you. So the steps we follow is a good exposure, good traction, counter traction, meticulous hemostasis. These surgeries are bound to bleed because there is a neoangiogenesis and it oozes a lot. So we have to be very, very meticulous in picking up these bleeders. Judicious use of instruments, because the ureter is very close, the bowel is very close, the serosa can be teared, and a good keeping the tissues wet, good copious irrigation, and you have to have a multidisciplinary team. The decisions, of course, would be made by the gynecologist, even deciding, because you cannot keep your bowel surgeon in your OPD and counsel them about this. You have to learn and explain and understand that how this surgery is going to be performed. Of course, for medical legal reasons, you need to have, I always have a bowel surgeon who fires the staplers, but the rest of the dissection is done by us. The whole bowel mobilization, the ureteric dissections, but finally, when it comes to stapling and firing the staples, it is the bowel surgeons, because there is 1 to 2% chance of leak and fistulas. Now, if you start performing a very high number of cases, then you are going to have these problems which are there in the post-operative period. So you need a good team, and we follow these patients when we do bowel resection or disc excision. We follow these patients by doing C-reactive protein and WBC count. Even if the patient goes home, our laboratory person goes to their home every alternate or 2 days and performs a C-reactive protein and WBC count. If the WBC count is rising and the C-reactive protein goes, the limit is 100. If it goes 100, the patient is called back to the hospital and a diagnostic scopy is performed. Do not fear to perform a relook laparoscopy, because sometimes these patients can have micro leaks and small abscesses which can give little bit of shivering and like mild pain or some fever spike. But do not ignore this. If the patient comes and tells you a complication, it is too late, because these are bowel complications and they are usually the sepsis. So you have to pick them up early and counsel all these things. How I counsel in my practice is, I tell initially if I perform 100 bowel resections, then I am supposed to do 100 colostomies. But we have understood that only 1 or 2 patients have this leak and they need this colostomy. So why 97 or 98 people are undergoing colostomy unnecessarily? So we perform no colostomy for any of you, and we monitor all 100 of you. So if we pick up that 1 and 2%, only those will end up with a colostomy. People agree very well, and it is not at all a problem, because they are suffering so much that they agree to all this, and they get convinced that, okay, maybe I am not amongst those 1 and 2, and why I should fear for this surgery. So we have to be very, very vigilant in picking up these patients, and then we should go ahead performing these surgeries. So the dictum, I'm coming to the end of my discussions. The dictum we follow in a very radical surgery is so sure resection. So sure is a small acronym. S is we first go in and we survey the abdomen, the sigmoid, and everything is seen. Then we perform the adhesiolysis and the ovaries are mobilized out of the pelvis. We use either the sutures to the round ligament, or there is a beautiful device which is called as the T-lift, which actually pulls the ovaries away from the operating site and your assistant is free. Then you suspend the uterus. Either you can suspend the uterus by a suture or a hitch, or you can use a very good manipulator. Then the next step is always perform ureterolysis, because like I said, deep infiltrating large endometriosis with just 3 centimeters nodule, the ureter is 80% oil. So you have to do a good ureterolysis, you have to do a good pararectal dissection, and then entry into the retrorectum, and then you excise. Once you save the ureter and save the bowel, then the rest of the things is excision, and you can be radical in that part and complete excision of the disease. So suspension of the uterus and tubes, like I said, then dissect from the pelvic brim. That is the very clean area from where you can start and identify the ureter, and go medial peritoneal incision on the ureter and expose the ureter for the ureterolysis. Then you can dissect into the uterine artery. When you see the ureter going and the uterine artery going above it, you can be very, very careful at that part, because if you cut there, bleeding happens, and then in that brisk moment we start coagulating, and then the injuries happen, or the thermal damage happens. And then we go to the uterosacral ligaments, expose all these tissues, and then come out with the excision of the severe endometriosis. I think I'll just play one video of a disc excision. Is it okay? I'll make it fast forward.
Yeah, please.
Yes.
Okay.
Okay.
Stop sharing this and
After the video, just find out any questions are there in the chat box.
Quit to it.
Hi friends, I am presenting a case of disc excision. Okay, so now I'll just share. Sorry. This is the case, and I'll start here. This is the ultrasound being performed. Can you see this?
Yes, sir.
Yeah.
And here you have that black nodule which was there invading more than 3 centimeters and up to like 6 millimeters. So it is not going too deep, but it is quite wide. So what we do is we fix the uterus first. Then we start performing from the pelvic brim. We start releasing the peritoneum medial to the ureter, and we do what is called as the ureterolysis. And anybody would say, oh, it's such a clean pelvis, and see, this is the ureter. So we go right up to the ureteric tunnel, and then we go up to the uterine artery. Okay, so we know where exactly the ureter goes under the uterine artery and where I'm not supposed to cause bleeding. So this is how I go beyond the uterosacral ligament and identify and keep the ureter till the tunnel. So now I will not injure it because it is out of my way and I can see the ureter. So that is the ureterolysis on left side. Then we do it on the right side as well. You can see the ureter. Now I'm doing the pararectal dissections. So after the ureterolysis, I come medial to the uterosacral, and here I'm cutting the pararectal tissue. So that I am now with the Babcock's, I'm holding the uterosacral ligament. So this is going pararectally on the right side. You'll still feel that, okay, this disease still looks so clean for me. Now I'm doing the ovarian suspension. This is the T-lift device which we have. You just pass it through the ovary. There's a plastic string which goes, and when you push it across, it forms like an alphabet T and holds the ovary. So you can just keep it away and the assistant is free to help you. This is the uterosacral and this is the left side uterosacral and pararectal, and I'm going beyond the nodule. So you go all around the nodule and then you actually come to start cutting the rectovaginal nodule, because you know exactly what is the depth of the nodule and both sides you have gone, and now you will start seeing that we are cutting into the nodule and this is the white appearing tissue. So here you will see this is the part of the tissue which is being cut, and I'm actually cutting in between the nodule. So you have disease on both sides. There are different schools of thought. Some go into the uterus and drop the nodule completely and the bowel. Some go between the rectum and the nodule and keep it with the uterus. I often go with the central part where I cut it on both sides. So this, I have that I developed for this white tissue, which is actually the rectovaginal nodule. So I know that this tissue is not bowel, this is the endometriosis, and I boldly cut into this, and I know to what level I have to go because I have cut distal to the nodule. So here you can see this white tissue hard, which is actually pulling the rectum, and that is the nodule which is there. And once you cut this nodule, then you have to keep on releasing this uterosacral. Only then this nodule gets released and the bowel starts moving down. So here again, some part of the nodule is still there, and this is the part which we are cutting and trying to drop the rectum down. So this is the rectovaginal nodule which has infiltrated, and here I am almost getting to the dissected part. So I know now the nodule is coming to the end, and I am cutting into the nodule and releasing the rectum from the torus cervicum. So here you have the vagina, and that is the dissected part of the rectum. So this is the rectovaginal space. Here again, fat is a good landmark which tells you that there is plenty of tissues around the bowel and you are in a good plane. So fat is a very good friend of us in performing deep infiltrating endometriosis. So here now we have released it into the rectovaginal space, and you'll see it starts moving very easily thereafter. So once we release this, now here you can see it moves out very easily. Now this is the normal rectovaginal space. So this is the rectovaginal space, the two layers of the non-villiers. And so now you can see the nodule is actually infiltrating into this part of rectum. Now this rectal is at the level of the torus cervicum. This is almost 10 centimeters from the anal verge. It is very, very important to know where exactly is the nodule. If the nodule is very low down, then it is near a very high pressure. The sphincters exert a lot of pressure, and then your patients can very well have a pressure leak. And so in a very low rectal nodule, we perform elective colostomy, very low rectal. But if it is up to 8 to 10 centimeter or higher, we do not perform colostomy, because here the rectum has the capacity to actually distend and not transmit the pressure. So in these cases, we avoid doing colostomy if it is at the, and no gynecologist has fingers of 12 and 13 centimeters. I think nobody can pick up these nodules on per vaginal examination. So it is the ultrasound only which will really tell us and identify these tissues. So here now you have the remaining part of the nodule on the uterosacral. So I know where the ureter is, and we are excising the disease which is on the uterosacral, and the other one which is lying is on the rectum. And once, I'll not share this uterosacral, and then we come. So now I'm going with a stitch on the lower part of a clean bowel wall. And then I pass the needle on the upper part. So in between these is the diseased rectum. And now we pass the circular stapler. So there is a one part is above, proximal to the nodule, and one is distal. So the nodule is fed in between. So you can see now, I'll tie the knot, whereas my bowel surgeon friend, he will actually try to oppose these tissues, and this will go in and eat up that nodule part. So I have to shave this nodule to actually engulf more and bring the healthy tissues. You cannot keep the nodule and try, because this will involve almost only 3 to 4 cc's. So you have to shave it off and make it thin, and then you can actually put it inside. So now clean tissues, rotate axis of the bowel, and then when you do, this is the disc excision, only the roof of the rectum is being cut. So you are going to get a patch, like in Maharashtra we call it karanji, where you have that half tissue, like you actually cut it half. Is it the same in Karnataka?
No, sir.
Okay, sorry. Yeah. So then when you open it, you will find that patch inside. Okay. So here the disease has taken up into the circular stapler. The lateral and the posterior part of rectum is not damaged. The nerves of the bowel are posterolateral. So this is a truly nerve sparing disease surgery. If you do resection, then you are cutting it across. So in those cases, the posterior nerves have to be dissected, especially the hypogastric on both sides, and then you actually remove the bowel part. So here now we are doing the air leak test. We have put in water and we are going to inject air and see if there are any bubbles. No bubbles, the bowel distends. That's a good sign. We always do air test and methylene blue test, because if it is air test will be positive only if it is through and through injury. Methylene blue will stain the area even if it is over dissected. So in those cases, I give in something like the reinforcing stitches. If I'm doing shaving, especially in disc excision, we actually know where we have cut and there is no areas of over dissection. So we always put a second layer of stitches, because the pressure will come on this layer first and not on the staple line. So this is the video of bowel endometriosis. So I think I have taken quite a lot of time. Thank you. If there are any questions, I would answer that.
Yeah, Dr. Vidya will ask the questions. She has got the chat box.
Yeah.
Dr. Vidya?
Sir, I had one question. Just
Yes.
one. Hello.
Yeah.
Sandesh, sir. This such extensive diseases, if it is in a young girl before marriage, how do you go about it, sir, post-operative?
Yeah.
Prevent recurrence.
Yeah, very good. See, first thing is, now this is our close doctors group. Let me be, I might sound very harsh, but there is actually The recurrence is not recurrence. It is incomplete treatment of the disease in most of the cases. Do you agree to this? It is incomplete treatment. Just draining the endometrioma and just pushing the uterus away is not the treatment of the endometriosis. So it is never recurred. It is always there. So if you really do a good excision and you want to prevent the recurrence, the best thing to do is to put these girls on progesterone, low dose progesterone in continuous fashion. So the most important reason for endometriosis to happen is ovulation. So if you do not stop this ovulation, the disease will come back. Okay, so if you put them on this low dose progesterone in continuous fashion, then it prevents the recurrence of the disease. Very often we have an idea that I will put Mirena. I will put Mirena. The Mirena is a locally acting. It will take care of only uterus. It will not prevent ovulation. So if you do a radical surgery and you think that Mirena will work for you, it is wrong. You have to put them on systemic disease, systemic medicine, that is progesterone and Dynogest also. But Dynogest is very expensive. Simple progesterone can be given. If the lady has, a lot of girls have problem with progesterone. I have seen a lot of people have depression and psychological problems. So you can then go with Dynogest. Yeah.
Sandesh, I do not agree with your statement that recurrence is not there.
No.
No,
Recurrence
just 1 minute. Just 1 minute. This disease is known for recurrence, and no surgeon can cure 100%.
Yes.
It may be 100% for you as a surgeon, but still there will be disease which is not removed.
Yes.
I think that will flare up, and that is the reason we put the progesterone, you know.
Yeah.
There may be so many lesions which have not been identified by us. And you know that recurrence rate in endometriosis is very high. The word literature itself says it is 37%. So this disease is known for recurrence. And that is the reason multiple surgeries, multiple complications. You can call it as a recurrence.
Sir, what he meant was, most of the time, the endometriosis surgery is not done properly, sir. Many a times we
can't say that they don't do properly.
Yeah.
But you cannot do 100% removal in a infiltrating surgery.
Yes, sir. But the
so
problem
you are likely
is
to leave back some amount of tissue.
Yeah.
True.
And that comes as a recurrence. That is what I have
most of the time, what happens, sir, what we get, many a times the surgeons who do not know the endometriosis surgery, they do the surgery and they just drain the ovaries and leave. That is when I think we say it is incomplete and we get that surgery after surgery.
The message what Sandesh is giving is that if you are a perfect surgeon, you attempt to do the deep infiltrating surgery.
Yes.
Am I right, Sandesh?
Yes.
Not only you are a perfect surgeon, unless you have a perfect team of
team also,
surgeon,
team and everything supporting,
and followed by a physiotherapist and a dietitian.
Yes. That's why it is a multidisciplinary now.
Sanjay, there is a question for you. There is a question for you. One thing is, in this deep infiltrating endometriosis, when there is a huge adenomyoma, do you position the ovaries, especially in infertile patients, for ovum pickup? I think there is one question like
that. If you perform ovum pickup in the frozen pelvis, very often you are going from the vagina into and you have very high incidence of pelvic abscesses also, or difficulties in getting good quality embryos, eggs, and because of the frozen pelvis. But I will show you the difference. When you do perform surgeries, I had that, okay, but it will take time. Okay, so if you perform these surgeries, you actually, when you perform adhesiolysis, there is a recent paper which shows that if you perform colorectal endometriosis surgeries, the fertility improves. These patients actually do well. A lot of them conceive naturally because there the problem was dyspareunia. The tubes are healthy. We follow what now in this case also you see it was so severe endometriosis. into the vagina and rectovaginal area. But the tubes are healthy, the ovaries are good. Okay. So in severe DIE, and if it is colorectal, the indications, if it is indication for surgery, do go ahead with surgery. The question is, there is a very big mismatch between infertility specialists and laparoscopic surgeons. The infertility specialists always feel that we will fire off the ovaries. Okay. And which is actually true, that all surgeries on ovary reduce, no matter whoever is the surgeon, the egg number goes down. That is for sure. So we have to be, there are a lot of 8 surgeries which we perform on ovary in infertility. So we are depending on what case we are treating, whether she's a young infertile, whether she's an old infertile or elderly infertile, or whether she has completed her fertility. All these things are different. So if you have to perform these surgeries, you should go ahead performing it. And I think that should be not the difficulty in restricting these surgeries.
You are trying to say that most of the time we defer surgery and it may be indicated. So a good surgery, there is a paper on that. A good surgery, endometriosis surgery, improves the pregnancy rates. Yes. So basically it is not thinking about decrease in the ovarian reserve, but giving the quality of life to the patient and improving the success rate in conception in endometriosis.
Yes, and to your question, we do not suspend the ovaries in endometriosis surgery. Only excision of the disease actually, and then the ovaries are left in their non-natural positions. So we do not fix them up into the brim or to the abdominal wall. Yeah.
When do you decide? I just want the points like this. Sir, just allow me to ask this. Sorry, sir. Go ahead. Just when do you decide, irrespective of the age? 1, 2, 3, 4 points on a colostomy in a case of endometriosis.
Yeah. See, colostomy we perform only if it is a very, very low rectal disease. That is within 5 centimeters, when it is 5 centimeters from the anal verge. Otherwise, we do not perform the colostomy. Secondly, we counsel her more if I am performing a hysterectomy along with bowel surgery, because then there are 2 suture lines. Okay. Then there are cases of bowel resection and disc excision in the same patient. Sometimes you have more than 1 nodule. So in those cases, again, our counseling differs. So elective colostomy, we have almost stopped, and fortunately, very low rectal endometriosis is there. The commonest is the sigmoid, rectosigmoid, which is actually more than 10 to 12 centimeters. So we do not have to perform colostomy electively in our cases.
Sir, just finish your question. I have one more question. Hiramat sir, you were asking something.
No. Question. Any other questions are there in the chat box?
There are few more, sir.
No, please pick up the. My request is please pick up the questions from the chat box.
Yeah.
The audience should be given first preference.
Okay. So
we go on asking questions.
Point. I don't think the audience will think about this because Lars, how often do you see Lars, Sandesh, when you do this discoid or resection, discoid resection?
Yeah, it will depend upon, again, Lars will depend upon which part of the bowel you are removing. If it is low rectum or you are removing a very large part of the rectum, then Lars happens very often. So if it is low rectum, then that rectum is lost. You have plenty of bowel in the upper part, the large colon and sigmoid and transverse colon and ascending colon. But that is not equal to rectum. You understand? Rectum is different. So if you remove rectum and bring a lot of bowel from above, it will not be the same thing. Rectum has to be, you have to conserve as much as possible the rectum.
So that's a very important thing, because we should not carry home the message that every discoid resection of the lesion should be resected to a large extent. We should think about the Lars syndrome also, which the patient suffers post deep infiltrating endometriosis resection.
Yeah.
One more question from the
I
audience.
just,
How long do you ask them to continue progesterone?
Yeah. Okay. The progesterone, how long?
Yeah.
It is continuous progesterone. Now my patients are there for 4 years, 5 years also. Okay. They are teenagers. They are yet still completing their education. They are yet to marry. So they continue with these drugs. And especially when they are on Dynogest, many of them, they continue with that. We just go ahead doing their liver function tests, and they are absolutely fine. And seriously, with every yearly ultrasound, we really don't find, and it is very heartening to see there is no recurrence and there is no pain, and the patient is really doing well in her career. So we continue it for long. And the point which we were discussing previously is, see, when bowel surgeons, initially the gynecologists were doing this resection also. So they were doing this enterotomy, they were cutting into the rectum and suturing it and preserving the rectum, because we were never taught the resection. When the bowel surgeons started coming into picture, the bowel surgeons are taught only resection most of the time, because the diseases they see are polyposis, rectum, or the ulcerations, Crohn's disease, or all these inside the bowel. Whereas endometriosis starts outside the bowel. So you cannot apply same treatment for both the diseases. In this, you have to be, and even God is trying to protect. I'm telling you, very rarely the endometriosis invades. So it will spread sideways. So we have to be sure. And when the bowel surgeons came, the incidence became almost, some centers started doing 90% bowel resection. Now again, when the disc excision started getting popular, so if you see reports of all centers, you should ask them, say, tell me how many shaving and how many disc excision and how many resections you do. And then if it is a uniformly scattered thing, like they are performing shaving also, they are performing more shaving, then that is a good center. It is not that I know resection, so I will perform resection for you. I know disc excision, so I will perform only shaving for you. That way is we are treating incompletely. We have to treat what is required, and there are good guidelines with ultrasound, and it can be decided pre-operatively, because all these guidelines are radiology based.
So the take-home message is, as far as possible, if the mucosa is, most of the time the mucosa is not involved, as you said, it is sideways. So it is shaving is the best. Only that is discoid resection only if it is necessary, but most of the time to prevent Lars, shaving is the best treatment. Is the shaving is the future or the best treatment for bowel endometriosis.
Shaving is very good. The patient will not go with new complaints.
Yes,
you understand. She has the shaving. The only problem of shaving is it is incomplete, and the recurrence, like sir said, 37%, that 37 highest is in shaving. If you do disc excision, it is still lesser. If you do resection, it is still lesser. So the technique will have its advantages and disadvantages. So shaving is good in the sense the patient will not have new complaints like Lars, like she cannot hold on to the stools, or she has to run to the washroom, and all these new problems will not arise for her in shaving. Or there is leak and she lands up with another surgery, readmission. So we have to accept this, and this has to be told to the patient.
Dr. Sandesh, could I have, there's one more question in the chat box, Vidya. What is the role of adhesive preventing barrier methods to be used? I think by Dr. Manjula Patil.
Yeah, in especially if we are treating a patient of endometriosis with infertility, then we always do what is that called as the EFI, the endometriosis fertility index. And depending upon the tubal status and how we release those fimbrias, post-fimbrial release and adhesiolysis, we always put the adhesion barrier, and we prefer to put the gel between the ovary and the fallopian. We just actually cover it with the gel, and we prevent the adhesions because she is for fertility. Secondly, between the rectovaginal endometriosis, there is no role of putting some barrier, and that will not prevent the disease or the fistula or leak, because that is happening from inside the bowel. So it has nothing to do with it.
Okay, thank you, Dr. Sandesh. That is very good. I have another very small question or a comment, I would say. I understand that deep infiltrating endometriosis has to be treated by a team of experts who have the competency in managing all these complications. But in the resource poor settings, when we get women who have this deep infiltrating endometriosis, they are not in a condition to reach such a team and pay for that team also. Then what is the alternate? What is best we could provide for them? Because in the rural setup, we do see many women who do not even have the affordability to come to a private hospital to get a regular surgery done, and they land up with this distressing disorder. And how do you manage them?
No, I have no answer for this because
it's quite a common scene, sir. They can't afford to go anywhere.
It is really very unfortunate. I agree. It is really unfortunate, and that is because we were not
doing it. Picking it up early.
There is no good referral system with us.
Yes.
Okay. So, like even me, when I was in the new initial practice, I also felt, why should I send my ovarian endometrioma? I can do, and when will I do? So I started doing it. When I went for my training with Adel, and when I saw his surgeries, actually in between 2-3 surgeries, I just went out and I held my head and sat down. Then Dr. Adel, he came out, he asked me, what happened? He said, doctor, I have to call all my patients back because all of them had this problem, but I never thought that this is endometriosis. So you have to develop that eye to understand. See, what we are doing, what we did initially was we just separated the tissues and the disease was there. So slowly, with students learning these techniques, seeing these videos, they will develop an eye, and very soon we will have a lot of centers performing these surgeries. So we should identify in our respective areas who can perform this and try to call them. And believe me, open surgery is very, very difficult in severe endometriosis. Laparoscopy is easier.
Yes, sir. That we agree on. That is definitely.
We are close, Bharti. We are close to 9 o'clock.
Yes, sir.
One small question, sir. Sorry, sir.
Last question.
Yes, sir. Following surgery, sometimes oocyte retrieval becomes very difficult.
Please put on your video, if you don't mind.
Yes, ma'am.
Thank you.
Hello. Good evening, sir.
Good evening.
Sir, sometimes after surgery, oocyte retrieval becomes difficult. Sometimes the ovary is stuck. So we face difficulties during oocyte retrieval. Sometimes it is adherent to the uterus. We may have to go through the uterus, and we are worried whether we are injuring the uterine artery during oocyte retrieval. So any fixation, anything a surgeon can help, sir, reproductive medicine for later oocyte retrievals.
See, where
can we fix the ovary?
No, if it is fixed to the posterior part of the uterus, it is better to go through the cervix and uterus rather than I fix it to the lateral peritoneum. Uterine is better than external iliac. And so I think, and it is difficult also for you to do ovum pickup if it is high up. So we allow it actually to fall into the pelvis. Okay. And a lot of times if the and we try to do this release of the pararectal dissection and the rectum is moved down. So you don't go through the rectum, because in I don't think people are given a good bowel wash and before ovum pickup. I don't think. So that is the reason you might be going through bowel and sometimes, but actually we don't fix it because we believe that it is better to have a good clean dissection and let the ovary be in its natural position rather than fixing it higher up, because that will really make it more difficult for you.
Okay. Can we practically, is it possible to fix it to the vagina, sir? Any problems we may face if we fix?
See, ovary, if it is fixed, no, these ovaries land up with recurrent cysts. That is very often if the patient starts having of infertility, has cysts, repeated cysts, lot of times we have found in our own practices that these, when you do a scopy, you always find some adhesion formation. So when you have some blood supply coming from different neoangiogenesis, cyst formation is very common. And putting it into the behind the vagina, then you are actually into the rectovaginal pouch. It is more difficult. Forget your ovum pickup. Then for lifetime, she will have cyst formation in that area, because post hysterectomy, in vaginal hysterectomy and abdominal hysterectomy, the cyst formation is more than laparoscopy, because these ovaries are covered with adhesions, and then there is more cyst formation. So do not fix it anywhere. Try, let it be in its natural position, and nature will take care to prevent adhesion formation between the two tissues. If we fix it, if we take the suture, then it is sure to form a severe adhesion.
Thank
So
you,
what was
Sandesh. We have come to the close to the program because we are crossing 9 p.m. Anybody, any questions?
Oh, so there are a lot of compliments. A lot of
No,
compliments.
please keep the
Compliments,
compliments later on. First, we will summarize it. Then you can give the compliments. Okay.
Dr.
At
Sandesh,
the outset,
just
I would
one-
like to thank Sandesh for having agreed our invitation. Sandesh, your talk was excellent. The reason is it has brainstormed so many people, so many questions, so many controversies. I think really your talk has initiated a very good discussion, and we are very, and I have seen you a decade back. You have grown so much over a period of 10 years, unimaginable. And your surgical techniques and your understanding of the disease endometrium and wonderful slides. You have picked up so beautiful slides. They were just looking like a surgical deliberation. You have done an excellent presentation. Only thing what I would like to tell you is that endometriosis has got the geographical variation. The way you are explaining such bad cases, hardly we see in our area. So much of bad cases where the bowel has been involved so much, bladder has been involved, and surgeries, hardly we see such cases. Maybe that areas we find it. And regarding your talk, you have highlighted about ultrasound mapping and discussing with the sonologist. I think that should be the most important issue, because many a times we never talk to the sonologist, we never discuss about this. He will give a report, then we see on our own the photos, then we make a mapping. I think mapping is excellent, and every deep endometriosis has to be totally mapped, like what we do for a malignancy. It should be taken as a malignancy, and a beautiful mapping has to be done. And MRI has come in a big way. MRI is helping us a lot, particularly in a deep endometriosis. I think a lot of questions have asked you regarding fertility and endometriosis. I think fertility and endometriosis itself is a very big chapter. There are so many issues to be discussed in that. But suffice it to say that whenever a woman has got an endometriosis, her fertility comes down. And if you want to improve her fertility, there are various problems, right from the quality of the oocyte and a technique to pick up the ovum and the outcome of the embryos. Embryo qualities are not good. So that's why endometriosis reduces the fertility of woman. But two things very important about deep endometriosis is hormonal functions are also altered. In superficial and ovarian endometriosis, hormonal functions are not altered so much. And immunology has also been altered a lot. That's why even if you treat them, you remove them, even a small tissue remains, the recurrence is going to occur. And regarding the pain also, I think you needed more time, because pain is another very important factor in a deep endometriosis. They suffer with such a bad pain. Even suicides have been reported in the world literature. That means imagine how much of the pain they do have. And the management of pain is a big difficulty, because we don't understand why the pain is so severe in endometriosis. In other things, we know what is the cause for the pain. But here the pain management is another very big problem. And psychology, that long-standing endometriosis, as you rightly said, they have to leave the schooling, they have to remain in the house, away from the society. So that's why in the world we have got a endometriosis support society group. So you log into that group. That group also will help you a lot. I think that has come in a very big way. It may not be in India, but in other countries, the endometriosis support group has come in a very big way. I think Sandesh, you have done an excellent the presentation. Everybody is very, very happy that after a long time we are listening to you. Probably you had come to our Bijapur conference where you did a workshop also, and after that we are seeing you. So thank you very much for the wonderful talk. Now I request others to give their compliments.
Kasturi Madam, please.
Yeah, very excellent talk, sir. Lots of take-home messages, lots of practical tips. Yes, this deep infiltrating endometriosis, we are always in a dilemma, especially in very young girls and unmarried or just married to manage this. Most of the time, we end up doing lots of conservative because we don't want to do surgery on these young girls. But your messages were very clear-cut and very which we can really implement back in our day-to-day practice. Only one thing I just wanted to know. I had a case which was a case of ectopic pregnancy. We had put a scope and we found that she had this chocolate cyst and also rectocysmal endometriosis. What you would have done during that stage?
No, you were treating her for ectopic.
Ectopic.
Only ectopic at that time.
Yeah. Okay. So I just wanted to know because
had pain also, you can drain the endometrioma. Okay. See, she is now case of she has family complete or fertility issues.
no, fertility issues. This primary ectopic.
Primary
Very
ectopic.
rare case. So just wanted to.
Yeah. So now there are so many things like you have to any endometrioma or anything. You always check an AMH levels because that is very, very important in making decisions. Secondly, her age, her fertility status, and whether she actually has some issues or it is a unilateral disease. So all this make very important decision-making points for us. So if she has pain and now she has lost this ectopic and that tube is going to be lost, then in that case, we have to be conservative. So we drain, and if it is unilateral and smaller, lesser than 5 centimeters, then in that case, we do cystectomy. If it is very, very large and it is bilateral endometriomas, we do not do cystectomy because we are very much worried about the egg number and egg quality. So each case would be different, and cystectomy is like a lot of times we wrongly interpret the literature that cystectomy has to be done to prevent recurrence. Yes, it is only to prevent recurrence, but in cases of fertility issues, we have to be optional that you can keep the cyst wall and still preserve whatever AMH because there is no cleavage plane between that endometrioma and normal ovary. Whoever is the surgeon will come out with normal eggs. So all this will depend upon each case, madam. Yeah.
Thank you, sir. Again, thank you once again for this excellent lecture. And I thank the whole Kcog team for bringing us such eminent faculty for the skill transfer. Thank you, Dr. Vidya Madam, Dr. Hiremat sir, and whole team. And thank you. We are looking forward to have you in person, offline, for workshops in future. Thank you, sir.
I take this opportunity to invite you all, especially the North Karnataka people on 5th next month, where we will perform deep infiltrating endometriosis surgeries, ovarian endometrioma surgeries, and even bowel resections. And Dr. Puntambekar will perform on CA endometrium and CA ovary. So it's an advanced course in Sholapur. So it's very close to Bijapur, Gulbarga, and all these areas. So North Karnataka, you are most welcome to be there for this workshop.
Oh, thank you, Sandesh.
Yeah,
Wonderful. Namaste for having made yourself free from such a long distance. And it was nice to listen to you.
Thank you. Thank you so much.
Thank you, sir. Dr. On behalf of Kcog, we propose the formal vote of thanks. Dr. Sandesh, we have no words to express our gratitude for sparing your valuable time and teaching us about how to manage the endometriosis the right way. And your mnemonic on So Sure, I think, will play a very important role when we manage such cases. We thank you very much on behalf of Kcog and Kcog. I thank our patron, Dr. M.G. Hiremat, for comparing and being with us through this program and making it more interesting. I thank our president, Dr.